So this is how we would log the 24-hour pH. You can see the normal pH in the esophagus is 4. If the pH falls below 4 in the esophagus, this is pathological. I say this because as practitioners, you may be sending your patients for a 24-hour pH study. If it comes back and says, look, 70% of the time your patient's pH was less than 4, that is very significant. So then you will ask me, doc, what's normal? So let's look at the normal. This is the normal, less than 4. The total time in 24 hours when you and I have a pH of less than 4 in the esophagus is only 4%. If somebody is from 4 to 8%, we say mild disease. 8 to 20, moderate disease. More than 20% of the day, if they have a low pH, it's severe disease. More than 35%, very severe, off to theatre. Because that group is not going to be helped by your omeprazole and pantoprazole. You understand? If somebody has 8%, 9%, I would just treat them with proton pump inhibitors. And that's how you'll find the patients. Is that autoplay? One more. Many people, the idea of putting see, you can see, this are the two wires going inside. There are the newer, Dubai is a fantastic place. It's like a Disneyland for adults, right? So everything is special and I like it. So instead of wireless, this is the Indian one where we have the wire inside, but now there's a wireless pH as well, you know. Wi-Fi, 24-hour pH Wi-Fi. So patients spend 24 hours at home and then they're walking around ambulant, 24 hours, pH monitoring. And that tells me very clearly, does the patient have a significant GER or not? Now, we go on to the last part, management, medical and surgical. And then I'll be off your back after that. So here we go. What are the goals? Somebody is sitting in reflux. Are my goals just to get this guy off? You know, take some Maalox, take some antacid and go. No, we aren't doctors for that. The doctors, because we want not only to relieve his symptoms, we want to prevent this patient from getting a cancer 5 years down the line. So I want to prevent complications. I want to heal the patient's esophagitis. And once my patient is comfortable, I want her to continue to be comfortable, maintain remission. Finally, if she has a stricture, I want to dilate so that she can eat well. If she has a bleed, I want to hit it with a laser so it stops bleeding. This is the entire goal of management. So you can treat it medically, you can treat it surgically. PPIs are fantastic. I think it's one of the greatest drugs in the world are the PPIs. But I'm going to tell you one or two small practice points that you can take back into your practice day after tomorrow. Many people I find give PPIs morning and night. Don't do that. Give them omeprazole or pantoprazole in the morning, and for night reflux, give them H2 blockers. H2 blockers work better at night when the patient is sleeping, tummy is empty. During the day, the patient is eating something, proton pump inhibitors work better. Always use a 24-hour proton pump inhibitor like lansoprazole or pantoprazole rather than omeprazole. When I do my surgical talks, I know this is not a surgical crowd, I get very angry if the guys aren't staying focused. I say, look, how can you work 8 hours with me and do a lap oncosurgery or something without taking your eyes off the screen if your heads are turning like this all the time? So I get like my boys to stay focused, but here it's different, I guess. So relative cost, you have to ask your patient, are you going to give your patient 20 years of omeprazole or are you going to stop it earlier? Medically, there are some people who cannot tolerate PPIs. Now, if they can't tolerate medical, jump to the next field. To whom will you operate? Now I'm coming to the very last part, surgical management. Many of you will ask, is there endoscopic management? Yes, there is endoscopic management. In Chennai, the first 6 patients whom I did endoscopically, it's called the endocinch. You can actually put an endoscope, very complicated procedure. You know, I always make, say, laparoscopic surgeries. After big open surgeries, patients go to the ICU and the surgeons go home. After laparoscopic surgeries, patients go home and the surgeons go to the ICU because we're sitting for 6 hours or 8 hours and operating. So after this complex endoscopic procedure for the lower esophageal sphincter. I did it for 6 patients in Chennai. All 6 eventually came for fundoplication, anti-reflux surgery. But the world is moving towards minimally invasive. So here we go. There is only some role for endoscopic sewing procedures, and they are still in a very embryonic or inchoate phase. We therefore have permanent solution, which is the last part of my talk on anti-reflux surgery. All right? I'm going to take another 7-8 minutes. Are we good, Nijam? Another 7-8 minutes? Or will they start throwing stones? You guys are okay? Good for another 7-8 minutes? Yes. Good. Please, for God's sake, talk back to me. I won't bite. Anti-reflux surgery. Indications. Failed medical management. 2. Patient preference for surgery. Many patients come to me and say, I take omeprazole, I'm all right for some time, and then it pops up again. One of the commonest reasons why I do this is the so-called hermit syndrome. You know, all of you know who a hermit is. A guy who doesn't eat, doesn't drink, So patients say, as long as they don't have cheese, as long as they don't have this, and this, and this, and this, and this, I'm all right. But I don't want to live my entire life like that. So, complicated GERD, once they develop a stricture or an ulcer or a bleed, you need to go after them. A large hiatal hernia, atypical symptoms with reflux documented, children with asthma, adults with laryngeal diseases, singers who are not able to sing because of this. All these require a permanent solution. So let's look at how we're going to give. Now I'm going to ask you to see this. This experiment was first done in 1922 by, well, 32 maybe, by Albert Einstein. All right, so stay with me. You take a soft straw, put it in the water, and suck on it, right? Will water come up? It may not come up, because if the straw is soft, the hydrostatic pressure of the glass will obliterate the straw. So how can you can either take off the straw and drink it, or you pull up the straw until it's just under the surface. I would like you guys to try it. There is physics and chemistry in every molecule around us. So you pull up the straw, the water will come. And this is the experiment. That's me with a straw. All right, that's a soft straw. I'm putting it in. I got a good length inside. I'm sucking and nothing is happening. Because this full length is here, the hydrostatic pressure of the water is compressing it. And then I pull it up till I give it a short length alone, and you can see the water coming down. Clear to everybody? So this is useful. One, for you to drink your juice next time with in case somebody gives you a very soft straw. More importantly, to understand reflux. Now, you saw the second part with the water going up. That is the normal reflux patient. After we operate and increase the length of the esophagus, that's the first part of the experiment. Are you with me? So what you saw in the second part of the experiment is what happens to patients with reflux esophagitis, because the esophagus is like a soft straw. So with only a short bit, stuff is able to come up. You make it long, stuff won't come out. And that's why you need to lengthen the esophagus at surgery. And this complex law is known as Poiseuille's law, where, flow is equal to 8 neta L by pi R4, but forget about it. So this is, you need to do your fundoplications properly. This is a paper that we published a few months ago. A patient who had a fundoplication elsewhere came to us again with severe vomiting, and you see this, such a huge dilated stomach on the CT scan with food debris. What had happened was, the fundoplication done elsewhere, the stomach turned on itself, so-called organoaxial gastric volvulus, following lap fundo. Then we had to set it right again, and we fixed it with what's called a sham GJ, just stitched it up there. A paper that we published in 2017, August, in the Indian Journal of Surgery. This is the Poiseuille's law, and I told you this is the length of the straw. And when I finish my operation, I'll show you now in the 1 minute 30-second videos how you'll find a good length of esophagus pulled back into the abdomen. All right, so we're going on to when do I interfere? Poor response to PPI, microaspiration causing asthma, asthmatic bronchitis, regurgitation, intolerance to medication. You are a GP, patient is sitting in front of you, or an internal medicine specialist, whatever. You want to know if the patient requires surgery. Simple technique. I ask my patients one question. You eat, you bend down. does stuff come up fully? And they say, yeah, doctor, the last stuff, the pickle, the curd rice, all that is kind of popping up to the top. The baba ganoush is here, hummus is here, then it's coming out. Or some people, youngsters, they'll say it's coming out through the nose. These patients are called high volume refluxes, and almost certainly they are not going to be okay with PPIs alone. So the symptoms of patients the symptoms give us a lot of clues, and every patient gives us a chance to be a Sherlock Holmes. As you know, Sherlock Holmes himself was based on a famous Scottish physician called Dr. Bell. So, of course, what I'm telling you is not an experimental procedure like this man is saying. Every time you blow your nose, you'll clear out your arteries. Experimental procedure. And this chap is saying, my company is involved in some genetic engineering projects, but I'm not allowed to talk about it. So indications for the knife. Nobody wants us. Surgeons, we are the scavengers of society. Oh, doctor, anything but surgery. But there are some things that you need to correct with the surgery. So when, on an average, 90% plus are satisfied with an anti-reflux procedure. Volume reflux, like I told you, if it's coming back, it's a good indication. Hermit syndrome, patient says, as long as I don't take anything at all but a couple of glasses of water, I'm okay. That he is living like a hermit, and intolerance of symptoms is a bad indication. Now, let's go on to what we do. Number one, we make the esophagus longer. Number two, we wrap the stomach around the lower esophagus to tighten the lower esophageal sphincter. There are various names. It's all for surgical boys. Don't worry. But you need some anti-reflux procedure. If somebody asks you lap or open, there is this myth. Oh, open you can see everything. Lap you can't see. Rubbish. In a lap, the kind of magnification that you get, exposure that you get, and I work out of 2 daycare centers. We're able to admit patients at 6 in the morning, operate upon them, and get them to walk home comfortably by 3 o'clock or 4 o'clock, minus a reflux. What I want you to remember, however, as doctors, is anybody who has a fundoplication will have a temporary dysphagia, because you are giving him, you're tightening up his sphincter. His body did not even have a valve. Suddenly you're putting a valve. It takes 10-15 days for the body to understand that. All right? So in the battle between keyhole surgery and open surgery, there's a no-brainer. Don't get your patient to have a huge gash. Morbidity is much less. Post-op stays 0 days now in my group. Recovery is excellent. Even in the last week, I was operating in a place called Hargeisa in Somaliland, and we had 6 patients who had fundoplications. 3 went home the same day. The other 3 were done in the afternoon, evening, and we sent them the next morning. So as far as possible, lap fundoplication. But I must confess, as surgeons, we are bound to speak the truth, that there has been a slight tendency to do more laparoscopic fundoplications, as well exemplified by the adage, when you have a hammer in your hand, the whole world looks like a nail. You see some of these guys in the rotary meetings with a hammer, they'll just be whacking this. If you have a hammer, you feel like doing this. So laparoscopic surgery is like that. The whole world looks like a nail to you. Now, in the very, very last few slides, I'm just going to show you videos. This is how we put the holes inside, and that's how we operate. I just want you to understand what you're seeing here is the esophagus. You see the whole esophagus has been pulled down. The chest of the patient is on that side. This is the abdomen. Can you see? These are the crural repair. This patient had a hiatus hernia. I'm stitching the left crus of the diaphragm. I'm taking you into theater with us, so come with me into theater. We're closing this gap. This is the gap. You can see this laparoscopic suturing is always a little difficult. It's like tying your shoelaces but using golf clubs. So we're closing the gap, pulling the esophagus away. Can you see this V-shaped thing? That's the diaphragmatic muscle into which the stomach had herniated upwards. Pull down the stomach, lengthen the esophagus, and these operations are absolutely bloodless. And we've actually even started doing single port fundoplications. I mean, just the belly button. And you can see now we have closed the crura of the diaphragm behind the esophagus. In this gap, if you go internally, you'll find the aorta pulsating. And to the right of this crus of the diaphragm, you will find the IVC. So yes, we are operating in a small area between the IVC and the aorta. Both are bad neighbors and don't like a needle into them. So you've got to do your suturing very carefully. You can see you have to use more of left-handed suturing and less of right-handed in some areas. So I train my boys, I ask them to shave one day with the left, one day with the right, one day brush your teeth with the left, brush your teeth with the right. That's how we train them, and you need to be ambidextrous. So that's about the crural repair. Now, this is the actual fundoplication. This instrument, all of you know the ultrasound. Many of you gynecologists will be using the ultrasound for diagnosis. This is where we use the ultrasound for surgery. You see, this is an ultrasonic machine that actually burns and dissects the tissue. I'm just showing you a dissection of the esophagus. This is the esophagus. I'm making it, lengthening it, pulling it. This is the OG junction, stomach below that. I'm going behind the esophagus, creating a space, and you know the stomach fundus is on that side. I'll find that fellow and pull him here, you see. So I'm catching the stomach to the left of the OG junction, catching it there, and pulling it to create a wrap. I just want you to understand the concept. All the videos are single 1-minute videos and 45-second videos. So, all right. So, and you can see now we got a little tape around the lower esophagus to hold it away. An important nerve called the vagus nerve runs behind, and it's interesting that the pleura will start coming in there, and you can see I'm freeing the esophagus. So that's the second part. Actually, it's very, very clear here, but obviously computers have minds of their own. Please remind me to end with a joke on computers. What you see here won't be seen there. They've got minds of their own. So are they male or are they female is the issue, computers. So you can see, can you see a hole there? I've created a gap behind the esophagus, and in this hole we have to travel through and pick it up. Now, I'm going on from there to the next because I don't want to give you, and you can see the last part, last video, or maybe second last. This is the right crus of the diaphragm, left crus of the diaphragm. The esophagus has been extended. You have the aorta here, you have the IVC here, the liver here, the left gastric artery. I think somebody there wants me to leave quickly. No, don't worry, I'm out. Last few slides. This is the spleen. You need to move the stomach away from the spleen. You are operating between the spleen on one side, aorta, IVC, mediastinum, right pleura, and you got to be very careful. But you can see now we're suturing again, suturing the crura. That's the left crus to the right crus. This is just to show you the devices that we guys use, you know. So Walter Scott said, "Oh, what a tangled web of lies we weave when first we practice to deceive." So you can see the various ways in which we cheat the body by using different gadgets like this to do our suturing. This is called the endostage. You turn it this way, esophagus here, stomach, stomach. Can you see that? And then you wrap it so that the lower esophageal sphincter, which malfunctioned for these patients, now becomes strong, now becomes reinforced. And you see, when you wrap it completely, take your sutures and you take it also to the gullet so that the stomach doesn't go up again, and the job is done. With laparoscopy, when I did the first one in 1996 or 1997, I took 5 hours for it. It's a learning curve. Now our average time is 20 to 30 minutes, and those times we kept the patient in for 3-4 days, all of us coming and asking, what are you, check his pulse, BP. Now we like a conveyor belt, patients just happily, comfortably, bloodlessly, painlessly walk out the same evening. All right, so you've seen the operation, technical details of the operation that I need not bother you with. Again, all these, this is sometimes patients have, when you do a manometry, you find that the esophageal movement is not enough. In those patients, we won't do a complete wrap. I want you guys to know that. I want you guys to ring up your surgeons or to ring me up and say, please do, but I think this patient has some dysphagia. Maybe you should do a toupee or partial fundoplication where you wrap around, but you leave 90 degrees of the esophageal circumference unhampered so that the patient will not have dysphagia. But the long-term results are best with the Nissen's fundoplication. I'm going to tell you the history of surgery is very interesting. The most intelligent man on earth between 1930 and 1940 was Albert Einstein. The man who created the fundoplication was Nissen's. Both of them lived in New York, New Jersey, Princeton. They're both good friends. Albert Einstein came to Nissen and said, please open me up, remove my appendix. And Albert Einstein used to walk around with a glass of milk because he had very severe reflux. So Nissen said, you're walking around with this milk, why don't I do your fundoplication? And Albert Einstein said, you open me up, please remove my appendix if there's nothing else, but please don't do fundoplication for me. I've seen all the patients, other scientists who had your open fundoplication, and I know they all are suffering from dysphagia because it is initially a crude operation. But over the last 90 years, thanks to minimal invasive surgical techniques, patients are very, very comfortable. And Nissen's fundoplication is the 360 wrap, Toupé's is the 270 wrap. And this is a Toupé. This is sometimes, the hiatus hernia is so huge. I found very often I have patients, the stomach is sitting next to the heart, such a big gap. You must pull it down, and it's not enough to just stitch those diaphragm closed, it will give way. Then you put a big mesh like this. See, it's like a U mesh. You go around it and reinforce the diaphragm, putting this mesh behind the esophagus to give it strength. So that's meshplasty, which we sometimes do. Conclusion. It's a cost-effective, proven, minimal invasive technique for permanent solution to a burning issue. Yes, there are technical details and there is a proper workup required by a 24-hour PH study. Never forget that there can be endoscopy negative reflux disease. Endoscopic intervention, in a year or two, I'm sure we'll all be able to start doing these things endoscopically, but it's still early. One hopes that endoscopic treatment does not flatter to let us down later. So these are some books that I've written. This is a textbook of surgery which I co-authored, which is now it's available in 18 countries. And this is a book purely on gastroesophageal reflux alone on my 20 years exposure. It's called Current Management of GRD, which I co-authored and wrote this. So I'm going to go past this, but that some of you can go in. Men can multitask too. It's a very nice, interesting, funny sketch video. I wanted to put it, but there are so many ladies here that I thought I would in the interest of decency, I took it away. I would like to thank all of you for not sleeping, and those of you who slept for not snoring. And yes, if you have any doubts at all, you can ask them, and I'm happy to clarify them. Don't ask me when lunch and dinner are, I don't know that. Anything else, I'm happy to. I hope I made it clear. It's important that we pass on information, dissipate knowledge clearly. All right?
Yes.
Please.
One of the complications in Barrett's esophagus.
Yes. That's a very good question. Could someone give him a mic? It's actually a very... See, he's asking about...
Similar to this GRD is the Barrett's esophagus, which is a key malignant condition.
That's right.
What is your...
Excellent.
What is your...
My take on it.
Not take.
Treatment.
What is this application going to do to the...
Fantastic question. Okay, right. So, somebody's already got Barrett's. Doing a fundoplication, does it prevent him from getting cancer? Now, the answer to that, so far, if you look at the data, they say just because you've done a fundoplication, don't leave the patient alone. The patient may still progress to develop a malignancy. The ideal time to correct reflux is before the Barrett's. Once, what people now, pathologists say that once Barrett's has happened, the process has started. So what we do in that patient, sir, I would endoscope, use an Nd:YAG laser, burn the Barrett's and destroy those cells completely. Then I would do a fundoplication. Then I would follow up on that patient year on year, scoping him. And 2 of my patients in my series, in the next 2-3 years, developed cancers. And then we went back and did an esophagectomy. And the patients are all alive and well. So, good point, good carry home message there. So what's your name, sir?
Dr. Sarkar.
Dr. Sarkar, good point from him. If your patient has a Barrett's, for God's sake, don't do a fundo and send them home. They may still develop cancer. Point taken, sir. Doubts, questions, comments? All right, I think we're done.
Any more questions?
Great. Only means one of two things. Everyone understood everything or no one understood anything. I hope it's the first. Thank you guys very much. I'll see you later. Bye-bye.